to react to what I call the department's next bold action, and you'll hear more about that. So we're going to go ahead and get started. There's still a lot of people getting food. There are benches. There's a bench all the way across the back. So if you have backpacks or purses on it, I'd ask you to take them off so people can sit, because we don't have enough seating, and we're going to try to get more chairs. This has been a phenomenal response and turnout, and I really appreciate everybody being here. So I am Jill Rockbeisel, the chair of the department, and I want to welcome you to the State of the Department that we try to do annually. Okay. Do I have to use this? Maybe. Oh, good. Okay. All right. This is our agenda. It looks kind of standard most times as we go through recognizing new folks, achievements, accomplishments, what our department financial picture looks like quickly, and then some information from each division, but I'm going to try to keep it brief, very brief. And then I'm going to present at the end, again, what we need to do as a department in times of uncertainty and how we're moving forward. And the good news is we're doing a lot and we're absolutely on track, but what do we need to keep doing? So we're going to talk about that at the end. I want to tell you there's a lot of slides that I'm going to talk at warp speed. Everybody gets copies of these slides. So for the detail on the slides, if you're interested, please take a few minutes and review them again. I'm not going to read all the slides. I'm sure you'll be relieved at that. So just starting out with announcements. I do want to announce the opening of the new Walter P. Carter conference room. Now, one of the things we need in this department is a big space to have big meetings. This is not finished yet. The tech isn't installed yet, but it will be hopefully by October 1. It is on the first floor, 701, in the back of where the old playroom was, and we ripped all that out, gutted it, redid the room. It is a beautiful room with windows across two sides, great lighting. And what you'll see is eventually, when this is finished, is there'll be a big TV screen here and another one over here on the wall. So people sitting along the sides have a better view instead of all the way down the end of the room. It's a long room. We have right now the table fits about 20 with additional chairs, I think up to 24. We can get more seating if we as a department realize we need more seating for bigger meetings. You book it through Kelly, my assistant. Either her number or my number will get you to her, and she'll keep the schedule. I just ask if people use it, to leave it as you find it. Don't take the furniture out of it. It's amazing when you have nice chairs, how they disappear. Don't take the chairs out. Please clean up after yourself, put the trash out in the receptacle, and leave it for the next person. In this project, I want to thank Marcia Gorth, who's here. Marcia, raise your hand. She helped. We worked together on this. Actually, I said what I really liked and thought, and she did most of the work. Ordering, organizing, it was great. Marcia's a great partner. So we already have it booked once. Dr. Reeves has booked it for the next research steering committee. So we look forward to you guys using it. Other announcements, just quickly. First and foremost, I want to thank Dave Castine. Dave, a special thank you. Dave has been our director of finance for the department for 4 years. His attention to detail, his stick-to-itiveness, his reliability, he always keeps us aligned in what is appropriate financially, and has really gotten us organized. And David, I really appreciate everything you've done for us, and I wish you best. He's moving out of academia into the finance world. So the best to you, and we will, of course, be trying to replace David, although that might be difficult. I just have a note to myself here. I am fully aware that there is, frustration, especially from some of the clinical division directors in trying to get information from back-end billing. I'm fully aware of this. We have a huge department with increasing load on our billing arm. And so what I would ask everyone, I'll give you an example very quickly, is that if you have a simple question or just need a simple answer, you can call Kim directly and you guys have her access numbers. But if you need data, if you need a table, if you need some regular reporting, I want you to email Afshan and myself. Afshan will be the lead on it. Now, an example of this, Afshan Qureshi is our senior administrator. An example of this is Dr. Weintraub came to me and said, oh, we've been talking about, shouldn't we be providing clinical addiction care to people with private insurance? Right now, we don't. We send them out to other people. Is that what we should be doing? So Eric said, well, can we even get paid? Asked Kim. Over 2 weeks, she provided 2 sets of data about how that would work with private insurance. Very helpful data. It would be difficult. That doesn't mean we won't do it, but we got all the information within 2 weeks and we're now digesting it. So nice example of we can get a quick turnaround if we're focused in the requests. And so those big requests come through us and we'll make sure that they get taken care of. All right. And then the last one is every faculty member, but this is also for staff and for residents, like senior residents. UMB, there's UMB employees. Well, they're UMB employees, but they said residents and fellows. So have a professional development coaching that is free, one-on-one, great service, something that ordinarily you would pay anywhere from $400 to $600 an hour for. And it is available to faculty and staff and trainees. So if you're interested, there is a website through UMB that you can get more information and apply. All right. So the next, and this is hard, we have a lot. We are growing in uncertain times. Keep that in mind. We are growing and we have brought on a lot of new staff. Now, remember that our staff are the driving force behind our operations. And I'm talking about business support staff as well as clinical staff. Anyone that's not faculty, they're our backbone. And so we need to recognize them and we need to engage them. And so there's a lot of names. Most divisions have new staff. Please make an effort to reach out, introduce yourself to new staff and engage with them. That engagement is what keeps people here. So I could ask, if your name is on this list, can you stand, please? Your name is on this list. Please stand. I had a funny feeling we wouldn't have a lot of the staff here because you know where they are? They're at their desks running the programs. They're doing their work while we're all here eating lunch. So I want to express my welcome and thanks to them. Faculty. Now, what I'm going to do with faculty, we have 2 slides of new faculty. We brought on 14 new faculty this year. That is a record in times of uncertainty. Keep that in mind. So what I'm going to ask is if you're here, when I call your name, please stand and remain standing. And when we acknowledge all the new faculty, then we will all applaud and welcome them. So our first one on the list is Rebecca Aronson. She finished her postdoctorate in child, and she joined us July 1. Rebecca, are you here? Thank you, Rebecca. Stay standing. That's great. Danielle Jones finished her CL fellowship at Yale and joined us August 11th. Are you here, Danielle? I don't see her. Angela Lee joined the faculty August 11th. She finished a community fellowship at UPenn. Or she's working in community to finish her adult training at UPenn and joined us. Angela, are you here? She's virtual. Okay, I forgot to mention, if you're virtual, you can unmute and say, I'm here. Mark Mazer finished his child fellowship July 1, joined us August 11th. Mark, are you here? Great, Mark. Stay standing. Anna Yagayans, I'm not sure I say that right. Every time I look at your name, I say it differently. You're going to have to give me a lesson. Anna, are you here? She joined us again August 11th and finished her fellowship at New York State. Yep. Great, thank you. How do you say your last name?
Yes.
Yes, okay, thank you. I apologize. Ryan Karzar, he finished his postdoctorate in child and joined us August 25th. Are you here, Ryan? Oh, okay. Cecilia Berguria. Cecilia Berguria joined us from Hopkins in the Collard Institute. Are you here, Cecilia? She's away. Thank you, Eric. Okay. Francis Chase joined us from South Carolina after kind of a long haul. Francis, I'm so glad you're here. He is hired as part of the department and also as part of Mine. So it's a joint partnership. Welcome. Okay, and a few more. We have Isabel Durr came September 8th. Thank you, Isabel. There she is. She finished her geriatric fellowship at UPenn and joined us here on the geriatric team. We do have Eliza Grossberg joining us November 3rd. Then we have, for part-time faculty, Jill Joyce joined us from private practice. There's Jill. Jill is amazing, 30 years of experience in private practice. She wanted camaraderie. She joined us. She hit the ground running. Thank you, Jill, for being with us. Emily Rosenwachs and Sarah Mahmood are both our CL Fellow graduates, and they both start in October and November. I don't know that they're here. Emily, are you here? No, Sarah, probably not. They're joining us. So what kudos to CL. So for those in the room and online, I think we should give them a big applause and welcome. Thank you very much. Who? Oh, for God's sake. She's like, oh, is Dr. Gupta here?
No, so it's okay.
Oh, good. I'm sorry. Thank you, David. Somebody's got to keep me in track. Okay. Oh, my. All right. Promotions. Record year. Record year. I am so proud. We have 5 faculty that moved up to full professor. If you are here, stand and remain standing, please. Dr. Ann Hatman, the Division Director for Community. Okay, we're gonna clap at the end. We'll never get through this. Cindy Schaefer, Division of Child and Adolescent. Cindy, yeah, there you are. Chris Welsh, Addiction. Is Chris here? Oh, there you are in the back. There you go. Okay. Dr. Reeves. Gloria, there you are. And Emerson Wickwire. Is Emerson here? Emerson's part of our department. He's a psychologist and sleep medicine expert. He does all his work in medicine, but he always stays connected. All right, we had 4 associate professors. Anik Forrester. Dr. Charles Robinson, the division director. Dr. Chris Morano, the division director of geriatrics. There he is back there, Chris. And then we had 2 of our new faculty from last year move up to assistant professor. So that's Caroline Corlieri. Caroline, you here? There you are. That's great. And Justin Young. Fantastic. We had and Hinda Dubin. I thought I was going to see Hinda. Is Cindy here? No. Hinda Dubin is part-time, works in education, and she moved up as well. Fantastic. 11 promotions this year. All right, is this, I had to look at this. So I could have gone back further. I just went back 5 years and looked at our promotions. First of all, Liz Tafita and I were talking, and everybody who was promoted knows Liz well, and anybody who was just hired knows Liz well. She's our faculty coordinator. We've never seen this many promotions. We've never seen this many full professors. We've had maybe 1 a year and many, many years, none. Same with associate. Past 5 years, we have had a total of 31 promotions. And in the past 2 years, as almost half of those promotions happened. Why? Because it is important that we recognize the expertise, the accomplishments, achievements of our faculty. And I think that hasn't been prominent enough. That hasn't been focused on. regardless if you're a full-time researcher or you're a full-time clinician educator, contributing knowledge to our field, everyone should be recognized and promoted accordingly. And so that is a priority for the department. And I have to say, we have 8 more on the docket reviewed for next year. I will also say we had 100% success rate this year and last year. So I'm asking every division director, I'm asking them to ask every faculty, and when I meet with you, I'm going to ask you about promotion. We want to recognize your expertise. So we've done a really great job. And Liz Tafita, thank you so much. Is Liz in here? She's probably out there. Okay, she is just a fun. We couldn't do it without her. All right, faculty appointments. Again, stand, hold your applause. I'm going to go through these next. I think we have 10 or 11 appointments fast. The first one is Dr. Dee Kelly, She, after 2 years of acting, doing phenomenal things. She is now our permanent director of the Maryland Psychiatric Research Center. Dee's here. I thought you were traveling. I don't know why I thought that. Okay. New Chief of Clinical Affairs is Stephanie Knight, Dr. Knight. Stand. New Chief of the Midtown Psychiatry for Midtown Campus, Alden Littlewood. She's remote. Okay, great. Dr. Todd Gould is the director of the program in neuroscience. Big job. Todd, are you here? I thought I saw you. It's great. Please standing. Samantha Latour, Dr. Latour is our new medical director of the Women's Mental Health and Reproductive Psychiatry program. Sam? Dr. Kelly Dunn was named, I think we've talked about Kelly a lot, but formally I want to announce she's the director of the Calder Institute of Addiction Research. Kelly, are you here? Yeah, there you are. Okay. And Collard reports directly to the dean, but I've already told Kelly we adopted her completely into our division, so it's fantastic. Laura Rowland is the new director of the MPRC Translational Imaging Research Center. Laura, there you are. Great. And we have 2 co-directors of the National School for Mental Health program. We have Drs. Jill Bonekamp and Dr. Brittany Patterson. Are you guys here? I thought I saw, yeah, there you are. I saw you. Yeah. We have Dr. David Mancini, who's now the Associate Program Director of the Adult Residency Program. We have Dr. Andrew Vandervaart, who is the Shepherd Pratt Associate Program Director of the Adult Program. I don't think Andrew's there. And we have Isabel Cito, Dr. Cito, who's the Director of Preclinical Medical Student Education. Isabel, are you here? That was the last one. All right, full applause for all of this stuff. All right, we're going to hand it over to David for his last departing debut.
Thank you, Jill. Good afternoon, everyone. So I feel like my parting gift is that we performed extremely well this past fiscal year 25. Arguably, our net margin was 5.6% on a budget of 2.5. So this is the highest margin we've generated as a department overall. Gross collections, what you're seeing here are net collections, but our gross collections were up $754,000 over budget. The driver of that is improvement in documentation and coding. PES, our psych emergency services, was up 33% above budget. Our psych associates, also known as our PA practice, that's the 4th floor 701, exceeded budget by 63%. Also new and growing programs, TMS, ADEPT program, generated $133,000, and our child psych testing generated $236,000. Last year was, in FY24 was, we finally exceeded pre-pandemic levels. That's the IDX collections graph here. Pre-pandemic levels were $3.4 million. We exceeded that by 3.6, and this year gross, 4.2 million. So this is a historic high in terms of gross collections. So give yourselves a round of applause for that. Now, I've always been about transparency. In addition to that, we'll be paying out over $600,000 in clinical supplements. That includes provider balances, ambulatory RVUs that we instituted this year, in addition to chair and division director discretions. So more to come on those exact payouts for each of our clinical faculty. In terms of revenue, so this is a comparison. The chart in the bottom is a comparison of FY 25 to 24. So you can see that revenue has grown by 3% year over year. State grants make up the largest portion of that at 32% overall. So something we'll continue to monitor going forward. And then grants. So the chart in the upper left-hand side is total awards, so just under 50 million. Proposals submitted, so this is calendar year comparison, 25 versus 24 through the month of September, so not full fiscal year, but we're seeing a drop year over year. We know some faculty have left, down at MPRC, but it's really important to continue to submit these proposals. They're what's going to drive the department going forward. Yes, not everybody is decreasing. Obviously, MPRC going up at 18 million additional total dollars submitted. So keep up the great work.
One more. Okay. One of the things that's really important is the issue of you're going to hear it over and over when I fly through the divisions, is looking for new funding opportunities, more collaboration, more outreach. And you can see MPRC almost doubled their submissions, but it has been a hard 9 months. Hard. First of all, I am so surprised we got all our state grants. The state was cutting. We have total of about $25 million of grant from the health department. We're providing services and all kinds of services, whether it's training or treatment to the citizens of Maryland. And in the end, I expected some grants to be cut and reduced and some to be cut altogether. In the end, we got every single grant funded fully. So I think that is a sign of the importance of our relationship with the state and the value of what we provide. It didn't get cut. So great news. Okay, department-wide, we've done a lot of things. I could have 10 slides on all the stuff that's gone on across, and this is everybody that has made accomplishments. We did establish an executive steering committee that meets quarterly. We are supporting researchers who lost funding or need more. We placed faculty recognition and promotion as a priority. You already heard that. We implemented metrics for incentives because it's hard to reward what you don't measure. So we have to measure stuff, and we're going to expand that this year to other areas as well. We exceeded our budget, as you heard. We successfully pivoted our DEI focus on engagement. We hired 14 new faculty and promoted 11, and there's much more. So lots going on, very successful year. I do want to share with you, I sit on both of the medical center and the system boards as the president of the medical staff. And at the center level board, there's Bruce Gerald, president of the campus. There's Mohan Sunthap, CEO and president of the system. There's Dean Gladwin there, my boss, and everybody, and the whole board. And they were talking about chairs doing things, and they were talking about departments. And Dean Gladwin didn't have to say a word, but he singled the Department of Psychiatry out as one of the most successful departments that is stable, in the black. We're one of the few departments in the black still. I don't know where we rank. Ashan, do you know? Never mind, we'll talk about it later. We're in the black in a very healthy way. And he said the department is just phenomenal. I don't have to pay any attention to it. I wish somebody would tell him that we don't need to meet anymore, but I don't think you bought that. So kudos to everybody in this room and everybody online. That, I mean, if one's successful, we're all successful. So I asked the division directors, what do you want everyone in the department to know about your division? 1 or 2 highlights is what I asked for. I got no less than 15 from each division director. I also asked what their goals were. So and it's hard because when you have such an active, engaged division and program, very busy, how do you whittle it down to one or two things? So I don't blame them, but what I'm going to do is just very quickly go through these. I do want to remind you the engagement committee, which is our DEI initiative, and I'm not afraid to say that, is focusing this year on engagement through action. So listen as you hear what people are doing in action. But being here today, meet somebody you don't know. Introduce yourself to somebody you don't know. I was at a table, one person was, Austin was there, didn't know the rest of the MPRC people. They introduced themselves. You now know 3 more people in the department. You have more connection. So that's just an example. Go ahead, try to do that today if you can. But we want to engaging people in conversation, inviting people to meetings, but engage people on a personal level as well. So that's our focus. Next slide, we're going to do education. Again, one data slide per division. The highlights, a great successful year. Thank you, Mark and David and your whole team for the work that you've done, expanding resident opportunities in their 4th year. Their goals and you heard about the new positions, the goals for education. This is important for everybody. The goal is to improve medical student ratings of clerkships as they go through psychiatry. And their curriculum is changing. So we want them to have a positive experience, but we also want to increase the number of medical students choosing to go into psychiatry. So, or interns, social work students, whatever student they are, trainees, we want them to go to mental health. So how do they do that? Well, they have a positive experience with someone in psychiatry. They get excited about it, and then they think about going into it. And so your role as a supervisor, teacher to any learner is keep in mind to share why you are here, why are you enthusiastic, and help recruitment, because we'll get more people into the field. Okay, then there's the Maryland Psychiatric Research Center with the Kelly. Again, it was hard to summarize this. So what I have highlighted is the collaboration with UMBC and the Brain Center, advancing the neurotechnology. I mean, this is an example of how do you expand yourself to be successful in a time of uncertainty. And Dee and her team are amazing at this. They have a new summer student program for career promotion. So they take students over the summer and expose them to research. And they, encourage, give a positive experience. The neuroimaging program now is part of the UMB core facility, which is fantastic. And we would still be doing clozapine REMS if it wasn't for Dee Kelly's hard push, along with Ray Love and everyone else on the team. We no longer have to do that. And I think Dee was a very loud leader in that initiative, and the FDA got rid of it. So that was great. Thank you, Dee. All right, lots of awards. You can see that Dee yourself, Dan, Shu Chen, and Seth Ahmed all got awards or honors. Their goal, I want to focus on their increasing philanthropic funding. They do have a facility modernization study going on that is going to happen, but it's probably going to happen in partnership with UMBC that now owns the land, UMB, and the state. And Dee is pushing that forward with her team, expanding collaborations. And what I found really interesting is that last bullet, targeting growth in the following: nutritional and metabolic psychiatry. Chris Moreno and I were talking about, cognitive decline and the development of dementia. And we started talking about what are the endocrine and nutritional elements here. And we're going to brainstorm with them and see what we come up with. Using AI in predicting mental health or emerging technologies that advance psychiatric care. So those are some of the things they're going to focus on. If you're interested in it, you know who to maybe talk to. Then there's DBSR, Psych Services Research under Dr. Melanie Bennett. Their highlights, they got their 5-year ROP01 renewal through the NIMH. That's fantastic. They helped sponsor through the training center 64 events that touched 10,000 providers in the state. And they conducted 700 evidence-based trainings. So phenomenal activity. Their goals, again, they're looking at patient preferences for using antipsychotic medication, studying that. They're wanting to look forward to services implementation in the community and VA settings, and they want every member of their division to be submitting new grants or preparing a new submission. That's the goal. Todd Gould for the Division of Biologic Psychiatry Research. Their highlights, Todd was actively involved in a phase 1 study with ketamine in healthy adults and was a co-author on the results of that study. And now that study's in phase 2, looking at treatment-resistant depression and also neuropathic pain. Majed Haraz, Majed, are you here? I don't see him. Hopefully he's online. Hosted 10 undergraduates and high school interns last year. It was just like a buzzing hive, and organized the first departmental postdoctoral fellow meeting and lunch. And we're doing it again sometime this month. So again, that's engagement through action. Their goals: broaden funding, foster collaborations, and providing a stable and productive environment for training. Excellent. Okay, Pollard. Highlights. Well, let me just say about Pollard that their involvement with the community is amazing. So their goal is build. So they're new. They got to hire, they got to get grants, and they got to connect with the community. And they're doing all of that. It's really impressive in such a short time, Kelly, that you have done as much as you've done. And they've established the Pollard clinical trial program. So that's fantastic. Their goals for 26. I didn't get any goals from you because I'm assuming you want to continue to build and you want to move into your new space. Is that fair? Yes. Okay. All right. Thank you, Kelly. Eric Weintraub, this is the Division of Addiction Research and Treatment. Their highlights, I kind of highlighted my own page, so I didn't. They got their 5-year HRSA grant renewed, again, phenomenal accomplishment, and they're expanding into treating rural Maryland, which is a major initiative for the state, for the campus, and for the School of Medicine, and Eric's right there with them. Eric and his team, his whole team. He's in 9 counties, 7 jails, 2 health departments. They've touched 1,000 patients in jail, providing Suboxone treatment and connecting them to care at release. They have 3 federal funded multi-site trials, and they got their 3-year max renewal. Their goals: training, implement a sports psychiatry expansion for PGY4s, fundraising, and building ongoing relationships with Pollard. So again, expanding funding, establishing collaborations, growing. Division of Community Psychiatry with Dr. Hatman, expanding specialty clinics. So I'll say this more than once, but what you do is you look around and see what's missing, what is needed, what can we do that is not being done or not being done well. So women's mental health is embedded in community. There's a team providing palliative care for people at end stage, and internal medicine. I'm not sure exactly what that means, Anne. So I'll talk to you later about that. I don't know what that means. Other things he's doing, you're going to hear, how do you build courageous attitude in your teams for bold action? Well, you make sure that your teams have the skills they need in their area of expertise to do things comfortably. And Anne is doing that. Training all her staff is in DBT and motivational interviewing. Working closely with other divisions in our department, and they resumed the Academy of Independent Living, which is a whole program that really helps our adults with serious mental illness live independently eventually. It's I think a great program. Their goals: keep expanding services and enhancing collaborations. The Child Division, phenomenal. Again, very active. Their whole theme of family and youth engagement is phenomenal, and they do that, if you look down this slide, in a very thorough way. I'm really proud of them. They reach 11,000 school-based intervention students, and it's divided as you see it. They train. They have every year, 20 social work interns, 14 fellows, 6 interns, 3 externs, and 5 postdocs. I mean, it's a powerhouse of training in that division, and they have impacted the field internationally. Goals, they want to, they're expanding their statewide clinical review for kids in foster care. So not just antipsychotics. They want to provide training for families that have that are challenged, maybe with kids that are struggling, and also focus on early childhood. So great goals. Psych services under Dr. Van Remmen highlights, they opened the Bridge Clinic. They expanded the BERT team. The BERT team is Behavioral Emergency Response Team. This team goes anywhere in the hospital or shock trauma that has a psychiatric emergency. We have it downtown. We have it at Midtown. And they also implemented mock codes for residents, which I think is a great intervention. Goals, they work citywide to help those frequent, what we call frequent flyers, which isn't really a great term, but high utilizers that need more support, and they're obviously not getting it. Division goals, increase referrals, increase outreach with telemental health, and implement a new curriculum for the residents in PES. Dr. Chris Miller is spearheading that. Geriatrics, there's your team. There we go. Their highlights, they're increasing dementia expertise on their team. Again, giving their team the tools they need to do a job comfortably and well. So they've increased, all staff have completed the dementia care navigator. And you can see under the goals, they're increasing capacity. So again, growth, skill development. They're also, I'm so excited about this. We're going to get two new psych units. So when this is done, all of our psychiatric units will have been renovated. And so we will, all of the 11th floor of the hospital will be psychiatry. The 2 units, 12, I just thought you might be interested in seeing this. They are kind of combined on one giant unit that can be divided. So they really kind of still 2 units. The goals for that division are increased capacity, both in Gero and in the esketamine, and starting support groups for folks with dementia. And I just thought you'd be interested in seeing this. So when you look at this, this is the whole design. This is the geriatric and adult acute unit. And these swivels are doors that you can open and close so you can divide the unit. Most of these are private rooms. So although we go from 28 to 26 total beds, we have private rooms so that we won't be closing beds because someone can't tolerate a roommate. We'll actually be able to serve more individuals. And then there's plenty of treatment space, office space for multidisciplinary interventions. So it's good. And then I believe if somebody here is from Child then extends up on this. So we'll have the whole 11th floor. CL. Now I picked this picture because Chuck's always telling me that his faculty are running all over the hospital. So I thought this picture was kind of appropriate. Highlights. David retired, Dr. Glavinsky, opening a new collaborative. What this is, a new program. We're helping survivors of violence in the shock trauma outpatient pavilion. That was spearheaded by Dr. Maddie Marks. Maddie, are you here? I don't see her. Great program, great idea, great collaboration. And then they recruited both their fellows from last year. So that's fantastic. Goals, again, helping the hospital adapt to the changes that are happening with the cancer center going up. It's disrupting a lot of stuff. And CL will be instrumental in helping people respond to that. Expanding resident experiences. And also they're working on capturing more revenue for the work that they do. And that's sometimes hard, but we got to figure it out. Midtown, they implemented an interdisciplinary patient group program, a more robust program. They also have a certification program for nurses, so they can do that face-to-face with seclusions. For those of you that are familiar with this, what does that do? Well, then we don't have to have a doctor show up at 3 a.m. to do this exam. the nurses can do it, but we train them and they get certified and then they feel better about their job. Like it's really a very good thing. Their goals, they're finalizing the discharge clause after discharge from the hospital that reduces readmission rate, and creating family education, focusing on what to expect. And the PA practice, I believe, is last for this one. And our highlights, again, we're expanding women's mental health. We expanded the PGY4 elective. And we got the adult team back up on the 4th floor, and it was no easy task. But I think we're up, we're operating, and it's much more cohesive for the adult team. We welcome Richard that joined our team and also began working on consolidating referrals. Practice, streamlining referrals, expanding telemental health or marketing telemental health. We'll get back to that. And we want to increase the number of patients. The demand is huge. So we want to increase the number of patients that we can see. And we have done a great job. We have a great team. Okay. So what's the plan? I think this is probably the most important part. So we're in uncertain times, and uncertain times call for bold action. And why do I say that? Well, again, we're in uncertain times. We know that, right? Politically, economically, scientifically, social, everybody's in uncertain time. And we are trying to pivot in directions that we know there's a need and that we can be successful while we're dealing with some of the barriers that the current administration is putting up for us. And so I do want to acknowledge here that, you know, we've been all reeling in different ways. And I might say the clinical arm is going to be reeling over the next 2 years as the state has to change the whole global budget care system. It's going to change, and we're going to have to change what we do, how we do what we do, I should say. So way more to come. The staff, particularly in the research divisions, have suffered. And why do I say that? Because we didn't know what grants were going to be funded. We didn't know, and there's some, they cut some grants midway. So the grant ended. Well, if you're staff on a grant, it ends, you don't have a job. But what we had to do is we had to give many layoff notices, 90-day layoff notices. Do you know what staff go through when they don't know if they're going to have a job in 3 months and they're trying to support their families? They've been with the program wherever they're at, whether it's Center South or MPRC, or we had large groups of staff that got let payoff. In the end, some of those, not all of them, we did have layoffs, but many of those got reinstated. But the trauma from that doesn't just go away. And I just want to recognize that. We're aware of that. Anika and I have talked about that, thinking about how do we respond to that? What can we provide for support for that? So I don't want that to go unnoticed. I think that the staff in some ways have suffered more than some of the faculty, but I don't say that completely. So Ranjay Gulati, he's a professor at Harvard Business School, says, in the face of uncertainty, leaders are often reluctant to take bold action. We saw that here on this campus, did we not? We saw that. We saw people duck and hide. We saw our campus president say, keep your head down, keep the target off our back. It's there. We can't avoid that. And there was this really fascinating article that talked about different responses that organizations and leaders have. You can freeze, too overwhelmed, can't make decisions. You can hunker down, hoping to wait out the chaos. We saw a lot of that. Or you can retrench, trying to protect your organization or careers. But the bottom line, as they studied all kinds of organizations, they looked at who succeeded and who failed. They looked at the Great Depression. They looked at recessions that this country has been through. And in the end, fortune favors the brave, not the cautious. Now, I wouldn't take that to an extreme. But the bottom line is it's the leaders that are bold, that lead their programs forward, that succeed. And that is who we are. So to take bold action, you have to have courage. And I like one of the things that Galati said, is that courage is a willingness to take bold, risky action to serve a purpose that you perceive to be worthy, usually in the face of abiding fear. And so this department has always done that. What do? We provide service, education, and research for those individuals suffering the most, that need the care the most. And we have a mission and we have values. And if you keep those things close to you and in the front, being bold is easier. And I can verify that. This is being recorded, right? Every time I meet with my boss, I get into a tussle because there isn't an understanding of our values in this department, and I'm forever defending them. And so far I'm winning, but I can't say that will go on forever. I mean, it's interesting. You have to be bold. There's 5 strategies. Whoops, did I jump to? There's 5 strategies that everyone in this room can think about and adopt to help move forward. And I just want to mention them quickly. You could read more about them in depth. But one is create a positive narrative. And I think I've been trying to sort of set a little bit of that positive narrative through this presentation. The stories we tell do have an enormous impact on our sense of understanding the wider world. So we tell our stories. We've been through this before. We've had threats before. And we figure a way to go over the barrier, or around the barrier, or through the barrier. We figure it out. And they say, go risk cutting, identify and mitigate the challenges and the threats that we face. I do this a lot. I look around and say, what's missing? What are the needs, and what are the challenges to bringing that to fruition? And you get a group around you that's passionate about that issue, and you move forward. Cultivating confidence. You have to believe in what you could do. So I mentioned that in order to do this, you have to train deliberately. You have to make sure that best practices must become second nature. And so that's where, if you're training your faculty, you're training your staff with the skills that they need, you can move forward more confidently. You have to have a big toolkit so that you can call on different skill sets in different situations. And you focus on what you can control and where you can have an impact. And I think that's really important. The third step is take small steps. We did this in ADEPT. There was a need. We weren't providing treatment for treatment-resistant depression. We have a lot of people being treated that aren't responding. So we thought about novel treatments, and we started small. We put it in a space that's small. We bought 1 TMS machine. We started with 3 ketamine chairs. We're going to 5. We don't have enough chairs, but we started small to evaluate how we were doing it and if it's effective. And then you decide, this is working, keep growing. This is not working, pivot differently. That's okay. So start small, find connection. It's a team sport everywhere. It's a team sport. There are a few lone heroes in this world anymore. You've got to have a good team around you. And the 5th one is stay calm. I can't always stay calm. This is probably an area I need to work on. I brought my pen, there we go. So emotional regulation is critical to manage your own feelings as you face freeze, fight, or flight. And so as leaders and members of the team, we all got to do this better. How can we be courageous? What aren't we doing that we should be doing? We should be asking these questions, right? We have done this, and I'm just a couple of highlights and then move on to the one piece I want you guys to look at. We're building clinical programs. We're hiring people. We're hiring 14 people. We're building clinical programs. Again, in a face of uncertainty. Why? Because if you grow out of the uncertainty, you remain stable, and we will remain stable. The clinical arm of this department is as equally important as the research or the education arm, and at different times, one becomes more prominent to help bring along the others. And so right now, the clinical arm in our department has a heavier load on our shoulders. That's okay. We can do it. We're building women's mental health. Dr. Edwards and her team is building child testing, which is desperately needed. And usually it's a 4 to 6 to 18 month wait for a parent to get their child tested. It's bad. We're going to try to we're partnering with shock trauma. We're developing specialty services. We're expanding county jails. We're doing it. We got to do, this is just examples. We're expanding training opportunities, and all of the research divisions you heard are looking for new opportunities for funding. We're pivoting. So the take home message here is we have to be courageous, take bold action, but calculate the risk and take it in small steps. I think that's really important. So what is the department's next bold action? Well, I asked myself, what are we missing? What are we missing? I always have the entire department in mind. So all of our arms, all of our divisions. Has anyone, I've been here for 36 years, and I've never heard anybody say, we need to have a face, a vision. People need to think of us in the community. There are pieces, but honestly, I remember talking to Sarah Edwards, and people in the city don't know that we have the National Center for School Mental Health. They don't know. The Department of Education knows because they fund it, but nobody knows that. If I talk to people in the hospital or at the campus, they don't know that. Why? Because we are not showing face. And that's a lot. If people think, oh, I need mental health care, they think of Shepherd or Hopkins too often. We need to have a prominent face to other providers and to residents of Maryland as the place to come if you need mental health services or addiction care. We should be the face. And I would say that we're not yet. You look at advertisements, you hear about ortho and cardiology and blah, blah, blah. But every time I go to one of the marketing teams, either the hospital, the school, or FPI, we're not a priority. But we are a priority. And I'm going to put us out there if I have your buy-in, because I can't do this alone. So with the help of Rob White, thank you, Rob, we're thinking about external marketing. So what I'm doing is taking internal resources that we're currently spending and pivoting it to hiring an external marketing firm for 1 year to see what the impact is. I don't know if 1 year is enough to measure it, but we're going to start there. Small steps. Actually, we only paid them for 6 months. So the idea is they do digital marketing, social media, print marketing. They do all kinds they'll do videos for us. They do great work. We have a relationship with them. They've done EAP marketing for Rob for 20 years. They've done a great job, never missed a step. So we're going to start there. So what I said to the head of Accent Interactive, Ken, I said, I have a faculty meeting on the 18th of September. Can you produce a promotion video for us for a program? And how we would do this is small steps. So we picked the programs that we want to promote. And I picked women's mental health because I think we're launching that. We want people to know about it. So he said, we'll try. So what I have to show you is it's 4 minutes promotional. It's kind of who's the audience? Providers that need their patients to see somebody for perinatal postpartum care, or patients themselves, families that see somebody in trouble. So our audience is broad. So I asked the women's mental health team to be part of this, and this is what was produced. Now I'm going to show it to you, and I really want your input. I want you to, now it's a draft. It's not, this is like the second rendition. It's not done. It's probably too long. It is too long, but it's an example of what we could do. So David, here. I just
click on that.
"10 to 20% of known pregnancies end with miscarriage. I became one of those numbers after having a second trimester loss between the birth of my daughter and son. My OB and her office staff checked in on my mental health at follow-up appointments, offered support, and discussed mental health symptoms and treatment options if I needed them. They were with me during a difficult time and it was comforting to know there was professional support available should I have needed that. This is why I'm passionate about what we're doing at the University of Maryland.
Up to 20% of women suffer from mood and anxiety disorders during pregnancy. This affects not only the mom, but also the baby. Untreated mental illness can lead to less engagement in prenatal care, as well as adverse pregnancy outcomes, such as low birth weight and preterm delivery. In the postpartum period, it can lead to difficulties bonding with the baby. Also, around 10% of non-birth parents can have mood and anxiety problems during pregnancy and the postpartum period. And if these mood disorders aren't treated, it can negatively affect the whole family.
At the University of Maryland, we provide compassionate, evidence-based mental health care for women who are experiencing depression, anxiety, or trauma related to their pregnancy or delivery. Every woman and family is unique in what they need, and we offer a variety of services to help meet those needs, such as therapy, medication, and education for fathers and partners.
Folks might find that pregnancy and childbirth are not exactly what they expected, and they may have some strong feelings like anxiety or depression that get in the way of their enjoying new parenthood. Sometimes people feel embarrassed or ashamed by that, or they're not quite sure what to do with it. Therapy is immensely helpful in processing and normalizing those feelings and giving you some ideas and strategies on how to deal with them.
I've referred many patients of our midwife practice to this program, and we've seen great outcomes with patients reporting better mood, sleep, and experiences with breastfeeding. It's so important to be able to offer therapy and medication management to our pregnant and postpartum patients, and we're so fortunate to have a specialty team for this.
In the future, we aim to expand the program and provide support for those who are struggling with infertility or need preconception counseling or have perimenopause mood disorders. We also want to support those who have suffered perinatal loss or NICU level care.
This program has been an invaluable resource to our families in the NICU. There is a significant need for new parents to receive mental health support while they deal with the various emotional and social stressors that come with having their child in the NICU. Many families have shared that the therapy services from the program have helped them cope with depression and anxiety symptoms. It's also helped them relieve the stress from having a new baby, especially having a baby in the NICU with health complications. So I highly encourage patients and families to use this wonderful resource.
Adjusting to pregnancy and caring for a newborn can be difficult, whether it's your first time or your fifth time. We are here to help. If you have previously experienced a mood disorder in your lifetime or postpartum depression, you're at an increased risk of developing mood problems again during pregnancy or the postpartum period. Some warning signs include not feeling like yourself, having more trouble than usual coping with problems, having trouble sleeping or sleeping too much, having difficulty connecting with your baby, crying a lot, losing interest in things you used to enjoy, feeling worried all the time, or having thoughts of not wanting to be alive or wanting to harm yourself. Our goal is for women to have access to timely, evidence-based care with providers they can trust. I think the University of Maryland can be just that, not only to the people of Baltimore, but across the state, from Western Maryland to the Eastern Shore. If you'd like to make an appointment, or if you'd like to refer a patient, simply give us a call. We look forward to helping you and your family live your best life possible.
Okay, Romy's here with me. It's my new grandson. I had to put him on the side. I did get permission. Okay, so too long. And how would we use something like this? One of the advantages is that the company can take a snippet of it, put it on social media. Or all kinds of things can be done when you have a video such as this. Now, again, this is a draft. There's still things to be improved. But I want and this is just one program. So when we start, remember, small, focused, and where is there a need? So what are your thoughts about this? What's your reaction to it? Please be open, honest. And how do you see something like this? This is just one avenue benefiting whatever it is you do or your programs.
I have a question about the company and the way that they are marketing.
You know what, we don't, this room is, I hate.
So I have a question about the company and how they would be marketing. So a lot of targeted demographics using social media, right? A lot of, on TikTok, Instagram,
Right,
things that I probably don't even know the names of.
right.
And so does this company work those platforms? And also, how are they, going to use this information to actually engage people? Kind of, we're make content that is engageable, because that is a big part of that.
Right.
For people not to just see it and say, okay, no, let's do that, but to actually look at it and say, oh, yeah, I'm depressed and I'm pregnant, or whatever, and say, that applies to me.
Well, first of all, they have experts on their teams. One team may be an expert in social media, whatever it is. I actually openly admit I don't do much social media, so I had to find somebody that did, because we need it. But they have an expert in social media, digital media, print media. They work as a big team, and how are they going to do it? Well, where are they going to do it? They're going to do it where we want it. They have to follow university, FPI, and hospital marketing standards. I had to jump through hoops to get approval to do this. I was told no department can do this. The heck with that. Be bold. And we push it through. And so they will do, Mark, what we want them to do. But they have lots of recommendations. And they do a lot of this for many different industries. So it's a smaller company though, and it's Baltimore based. So they know Baltimore. They say to us, who's your audience? Who do you want to try? When we first looked at this, it was all white. And one of our team looked at it and said, wait a minute, that's not our population. And so they went back and got B-roll that was more appropriate. I mean, they get feedback and they do what we want and what we tell them that we want, but they are experts and they have a lot of input. I mean, recommendations, let's put it that way. Does that answer your question?
Yeah, I mean, I guess the kind of the reason that is coming up to me is watching this. I obviously am not a woman, so I'm not
right.
going to have the same experience watching, but I also know from my own patients, right, in child and adolescent psychiatry, the parents increasingly being my age or younger, that there's a lot of things that I would imagine don't kind of hit the same or land the same way for this particular demographic, right? For target audience. And so I guess that the question is it something where this company has that there is that plan to expand from this one first step to, to other divisions and maybe even beyond psychiatry if it's successful, right? But is that something where it's expandable, where they have that they express confidence in expanding that?
Yes. In fact, to do this, they had to sit down. They met with us as a team. I actually was on vacation at the beginning. They met with the team to say, okay, what do you need? What do you want? What's your message? Who's your people? Who's your target? And so you have to talk through it with them. And then they go away and do something and bring it back and show it to you. And you talk through it again. Again, and so is it expandable? Yeah, we start. I just picked a program because I wanted to show you guys something. And it's not always going to be in this format. It certainly wouldn't be this long. And where would we put it or do with it is up to us. I do know one thing for some of our programs, we need to reach all of the providers in the state. Like if we want referrals to come in, we have to reach the professional audience as well. That wouldn't necessarily, I mean, this lends itself to that a little bit, but it's really focused more, I think, on patient engagement. Eric.
I thought Sam did a great job. I think my question was, there's kind of the academic or educational piece, and then I don't think Sam should be saying call. If I have a lawyer, do those clerical saying this number, that it should be done differently. She should focus more on like describing the program. I thought having those numbers flash up during the presentation, she didn't take in mind. That's just kind of me looking at it,
Well, so the idea is it's promotional, and
but maybe at the end.
so you think the numbers showed up too much?
I don't think Sam should be saying.
Oh, that's
Great
interesting.
job doing.
Right.
Describe. Yeah, that's kind of her.
That's interesting.
That's to me, that's cool.
So it's like she's promoting herself.
I don't know, there's just something about.
Something that doesn't fit right. So that's the kind of input you need. That's the kind of feed that they need. You know, you look at it, you think about it, and you say, we want more of this, less of this, take this out, do it differently. Sean?
I think you might be touching on, it felt too staged. It felt staged and it felt a little bit forced, some of it.
It was staged. It was done very quickly. Right, Sam?
I was just saying that might be a little something. I agree, like, in terms of, if you're saying that's not the type of content that's gonna be turned out, but
No.
in terms of feedback.
We had to put this was put together very quickly. It was, and we said, show up here and Sam's gonna be here, show up here, Rachel's gonna be here. It was all staged, every bit of it. So good feedback. Again, and you know, the content of this is a draft. There's a lot that can be done, but think about how would you use if you had access to something to help you get your face out there? How would you use this? Chuck?
This sort of falls between two categories of communication. One is educational and the other is kind of outreach, advertisement, however you want to think about it. And that maybe we should be thinking about targeting both ways. What this sort of seems to me is to mix the two things. Okay, that was kind of what made me go with one.
Okay, that's interesting.
Our Max program, we've continued to talk, and at the end, there's somebody that presents Max if you need help.
Oh, gotcha. Okay, good. Richard?
Well, it's important to remember that nothing about us without us can drive what we're doing, and I'm wondering if they talk to women who use these services. Needed.
So I actually had a patient of mine that I treated her in the postpartum period. She did fabulous. She is actually a nurse at the medical center, and she's done phenomenal. So I said, are you interested in giving testimony? I mean, I'm still see her, but I gave her that opportunity. She was thrilled because she works here. So if people around here see this, they're going to know her. She said, I'm thrilled. Women don't get the help they need. If I can help communicate that need, I want to be part of it. The problem was this was such a short timeline. They have her on the docket to interview her in the next week or so, but it couldn't be done for this. But I agree. We need more patient experience directly from the individual that received the care. That would help. And we just couldn't get it together for this.
Focus groups to find out what they would find and what they like.
Yeah, right. The focus group is excellent. So in marketing, you absolutely have to do that. You're right. Back there. Yes. Curtis.
My word would be that brown and black women don't look at that anything up.
So we, like I said, we recognize that this wasn't exactly our community, but they asked us, well, what about your staff? Well, this is part of the problem we have in the department. All of our clinicians on the women's mental health program are white. And we're just sitting there like, well, then, you know, we entertain the idea of having somebody step in, and we don't want to be fake about it. We didn't want to pretend somebody was something they want. So that is something we have to work on. We have a vacancy right now for our coordinator, and that is a role that would be well served in the community to have them more like them. So we're working on that. But Curtis, I agree with you. Yes, Jill.
Oh, I just want to say I've been in the community in practice for 30 years. I don't hear much about you guys. There's a huge number of you here. And I haven't heard very much about what you do, and you do a huge amount. Every day I turn around and I'm stunned by what you're doing. And I do think this move is a good move, whether this ad is good or not.
This is just a sample.
I think this is a really important.
Yes, Jill, thank you for that. I appreciate that. We have a couple Jills in the department. It's kind of weird for me, but thank you for that. I love that. Well, this is kind of like a focus group, somebody from the outside, although you're not outside anymore, that can come back to us and say, we don't know who you are. I mean, this is why I think we need to get ourselves, we need to be a face in the community. How do we do that? And, you know, I just wanted, yes, Alicia.
But if I assume that this company is sophisticated at tailoring it to different audiences, Because it seemed kind of in betweenish on that front as well.
Right.
That this would not be something to providers, but it wasn't quite to potential patients or supporters. So, I mean, just, we really have to be focused on different audiences.
So that's super helpful. Yeah, I mean, you can't try to do everything in one thing because then it doesn't work. And so that's great feedback. I appreciate it. So what I'd like you to do, again, this is not perfect. It's draft. We looked at it again last night. And it's a lot better than the first version. Sam, you saw the first version. This is the first time you saw this. Do you think this is better?
It is better in that there is less of us talking.
Yeah, more B-roll. Yeah, well, I mean, because it was just too much talking and it was too long, so we chopped some stuff. Anyway, but this is just like what are the possibilities? So what I will do is at our faculty meeting, I'm going to bring Ken and maybe his team, and he can talk a little bit about what the possibilities are. But in the meantime, we don't have a faculty meeting till November. In the meantime, I want everyone here to think about if I had to market something about my program, my division, whatever, the department, whatever, what would it be? And what do you think would be effective in your area? We do so much and most people don't know what we do. So we got to change that. I guess that's what I'm pushing. All right. Any last comments? Yes.
You mentioned earlier that this may be a 6-month to 1 year project. And so I'm wondering what is their capacity for helping the division and or department, and how will department leadership prioritize which divisions receive services from them for advertisement?
Great question. I think what we did, I think this may be some of the role of the executive steering committee. That I want, first of all, what are we going to do to onboard them? They need to get to know us. So I'm going to bring them to a clinical division steering committee. And then they're probably, if we pick some areas with them to focus on, they're going to bring themselves to your individual meetings, division meetings. They're going to get to know you. They're going to have connections with you. We're going to work at this. I said 6 or 12 months, meaning this is a pilot. And it's not cheap, but I'm just reallocating already existing resources to something I think would be far more effective than what we currently have. And we'll see. You'll be the judge. I mean, everybody has a say in it. This is a departmental initiative. This isn't a Jill Rockbeisel initiative. So just want you to think about that. Where we focus, what division we start with, it depends on what you bring forward. If you're excited and you have a good idea and you bring it forward, it's going to get seriously entertaining, probably worked on. And what are the priorities of the division and of the department? Cindy.
The commonality in 2022, maybe the biggest opportunity to revive our website.
Oh, I talked to them about that.
Thank you for investing in the. I think it's a wonderful idea, and that way the direction we need to go in.
Okay, so here's the other little secret. Although if I say this out loud and it's recorded, it's no longer a secret. So our website's just, when I think of a nice word.
Ineffective?
Yeah, they're ineffective. They're terrible. The hospital website, we have almost no control over, and it's crap. And the School of Medicine is so rigid and so slow, it's hard to get things changed in it. So we're going to have a separate website, but you can't say it that way to the school or the hospital because they won't like that. So they're going to work with us to develop an access website that people go to find out more about us. But what are they going to find out about us? What do you want them to know? Right? This is a team sport. It's not all up to me. All right, it's 1:30. Thank you everyone for staying so long. Thank you for your engagement. So
I guess the visitor